Hello, I'm Dr. Drs Grossberg. I'm professor and director of the Division of Geriatric Psychiatry in the Department of Psychiatry and Behavioral Neuroscience at St. Louis University School of Medicine. Welcome to episode 4, Parkinson's disease psychosis in the long-term care setting. Joining me today is Dr. Amita Patel, an esteemed colleague, a true expert in long-term care, who's director at the Joint Township District Memorial Hospital in St. Mary's, Ohio. I want to welcome you, Amita, and we look forward to having a great podcast together.
Thank you for having me.
We're going to be talking about the relationship between Parkinson's disease psychosis and institutionalization, how to screen for Parkinson's disease psychosis in the long-term care environment, the importance of recognizing Parkinson's disease psychosis in the long-term care setting, appropriate therapeutic approaches to manage Parkinson's disease psychosis, particularly in the long-term care setting. And then toward the end, I'm going to ask you, Amita, to discuss with us when you would refer to a specialist or try to seek specialty consultation. Before we get to the various aspects of our podcast today, let's kind of talk about how we define Parkinson's disease psychosis and really how common it is, whether in the long-term care environment or in general. So initially, before we talk about psychosis in Parkinson's disease, of course, we need a primary diagnosis of Parkinson's disease, which is generally based on the United Kingdom Parkinson's disease brain bag criteria. Once we've firmly established a clinical diagnosis of Parkinson's disease, here's what's required. At least one of the following symptoms, hallucinations, which we kind of broadly define as abnormal perceptions without a physical stimulus, and most commonly with Parkinson's disease psychosis, it's visual hallucinations, or delusions, which are kind of firm false beliefs despite evidence to the contrary. Most commonly, the delusions are paranoid or accusatory, or illusions, which are misperceptions of real stimuli in the environment. And then lastly, false sense of presence. This is a unique symptom in Parkinson's disease psychosis, where the individual senses that there's someone else around, but there is in fact no one else looking over their shoulder. Also very important is the notion that these symptoms occur after a firm Parkinson's disease diagnosis. And we also want to keep in mind that they need to be recurrent or continuous for at least 1 month. Let's talk about the epidemiology and the burden of Parkinson's disease psychosis. So one of the things that we know is that about 50% or half of patients with Parkinson's disease will experience psychotic symptoms sometime during the course of their disease. What we also know is that there's a high association between Parkinson's disease psychosis and activities of daily living impairment or disability. There's a high association with depression, with lower quality of life, with increased care partner burden, and with increased risk of not only nursing home placement, but also morbidity and even mortality. Now, fairly recently, there was a study done looking at the relationship between Parkinson's disease psychosis and institutionalization. It was a large retrospective cohort study done between 2007, 2015. They found that after 1 year, individuals who were diagnosed with Parkinson's disease psychosis, about 12% of them were in long-term care, some type of custodial care, versus close to 4% of patients without psychotic symptoms. At 5 years, patients with Parkinson's disease psychosis, nearly 26% were in long-term custodial care, compared with only 10% of Parkinson's disease patients without psychotic symptoms. So showing us that the relative risk for institutionalization in patients with Parkinson's disease psychosis was about 3.4. So these individuals are more than 3 times as likely to end up in the long-term care setting. Now let's kind of turn to you, Dr. Patel, Amita, if you don't mind. And I'm really curious about your recommendations and your procedures on how do you screen for Parkinson's disease psychosis, and how often do you recommend that we all should be screening?
So when patients are in long-term care setting, whenever patient is admitted to the facility, if they have a diagnosis of Parkinson's disease, patients are not going to be coming forward and really talking about their psychotic symptoms because they do not associate psychosis with Parkinson's disease. So we have to include psychosis assessment with the initial assessment when they are admitted. We have to do regular assessment for psychotic symptoms in all residents who have Parkinson's disease diagnosis. And then whenever we do a quarterly assessment of our patients, we have to do, again, repeated assessment for psychotic symptoms on a quarterly basis. Now, in long-term care, it's not only that the physician is doing the assessment. So the psychotic symptoms are noticed by the physician, the nurses, the unit managers. It could be the physical therapist, the occupational therapist, the speech therapist. It could be the ancillary staff. It could be even the housekeeper. It could be the nurse's aide who's taking care of the patient, who's giving the ADL care. We also involve the family members in asking them if they have noticed any changes as far as their behavior, or they have noticed any other psychotic symptoms during their visits or interaction with the patient. So it's a very multidisciplinary assessment that we do on a regular basis. But we never associate psychotic symptoms automatically with Parkinson's disease. We always like to exclude other medical conditions like any metabolic changes, any infections that patients may develop, any changes in their medications. It could be that their Parkinson's disease medications were titrated, patients are on pain medications, other medications that could be contributing to their psychotic symptoms. It could be anticholinergic medications or other primary psychiatric conditions that can also cause psychosis.
Yeah, I think those are very important points. I had a couple of thoughts about what you just kind of reviewed. The first was about the importance of the housekeeping staff in the nursing home. I saw a study, fairly recently that looked at who are the people that spend the most time with patients one-on-one in the long-term care environment. It's often that housekeeper who's with the patient in the room for a long period of time. And if they're aware of what to look for and what to report back to the nursing staff, that can be obviously very, very useful. The second point that you brought out, I think, any and all causes of delirium would be the first thing I'd be thinking about before we kind of automatically say that the psychosis in this Parkinson's patient is coming from the underlying disease. I think an important issue, which I wanted you to kind of talk about, I know this is part of your areas of expertise, is the notion of coding or appropriate coding for Parkinson's disease psychosis in the long-term care environment. So I wonder if you could share information about coding with us.
So by the time the patients arrive in a long-term care setting, they're pretty advanced in their Parkinson's disease. So it's not uncommon that along with their Parkinson's disease, they also have Parkinson's disease dementia. So when you code, it's very important to know whether they have only Parkinson's disease with their psychosis, or they have also Parkinson's disease with dementia with psychosis. So when you code, you have to code for Parkinson's disease and then code for either hallucinations and delusions, whichever they have, or code for Parkinson's disease and then code for dementia with psychotic disturbance. And that can be dementia unspecified, mild, moderate, or severe. Now we have specific code related to Parkinson's disease related dementia with psychosis.
So that's, I think, a real advance, and it's something that we didn't have before, related to the point that you made about how by the time patients move into the long-term care arena with Parkinson's disease, that they often also have accompanying dementia. We actually published a study a few years ago looking at Parkinson's patients in our teaching nursing homes. And we found that the overall prevalence of Parkinson's disease was between 8 and 10%. And then we went further to look at what percentage of those individuals met criteria for Parkinson's disease dementia. We found about 50%. It could be even higher. So I think the coding can be very useful for us. Once we've kind of established that a patient has Parkinson's disease psychosis, we need to start thinking about what are our treatment or therapeutic options. Generally speaking, it's always a good idea to think non-pharmacologically first. So for example, if the individual is having illusions, misperceptions of things in the environment, we want to make sure that they're not having any visual problems. They've had a recent eye exam. Adjusting lighting in the environment, or minimizing noise or distractions, and so on. Particularly if the symptoms occur when you have a low light in the evening or low light time or environment, there are things we can do in the environment to improve or to modify the psychotic symptoms. We can also talk about behavioral or psychosocial strategies or interventions. Whether it's music therapy or other sensory therapies, activities programming. Sometimes in the soft psychotic symptoms, we can use diversionary activities, and that may be enough. But of course, that's not going to work for everyone. And many individuals, in fact, are going to require pharmacological approaches. And Amita, I wonder if maybe you might talk about the different pharmacotherapeutic approaches and what are the options that we have?
If the psychotic symptoms really start to impact the quality of the life for the patient, and we see that the symptoms continue to persist, then we really need to think about using pharmacotherapy options for these patients. The International Parkinson's Movement Disorder Society recommendations really look at different pharmacotherapy options. They have looked at clozapine, which has shown some efficacy, but you have to have weekly CBC. So it really requires specialized monitoring, which is so difficult to do in these patients. Olanzapine has not shown any efficacy. It doesn't have acceptable risk, and it's not been found to be very useful. Quetiapine, it has acceptable risk without specialized monitoring. It's possibly useful. Pimavanserin, which is FDA approved specifically for this indication, found to be very efficacious with acceptable risk without specialized monitoring and clinically very, very useful.
So I know that you work in the long-term care environment, and obviously you're a specialist yourself, but let's assume that we put ourselves into the shoes of the primary care physician who is taking care of patients in the long-term care setting. When should they be considering kind of calling in a specialist for the patient with Parkinson's disease psychosis?
When a primary care physician notices that a patient with Parkinson's disease has psychotic symptoms that are persistent, I would highly recommend a consultation with a psychiatric nurse practitioner, a psychiatrist, or a neurologist. Normally, it is really difficult sometimes to get the psychiatrist. Most of the facilities now have psychiatric nurse practitioners that manage these patients with supervision by the psychiatrist. So really, or sometimes there is a neurologist who is available, or the patients could be sent out to be seen and managed by the neurologist, or tele medicine consult with a psychiatrist or a psychiatric nurse practitioner is also available.
Yeah, I think you're making some excellent points. You're also pointing out how difficult it is often to find specialists, particularly those that may be able to come in person to the facility. Hence the greater use of telehealth or telepsychiatry. I'm reminded that we are providing telepsychiatry consultations to a long-term care facility in Northwest Missouri, a rural area. They don't have a psychiatrist or neurologist, but they're turning to us, and we're over 200 miles away to provide telepsychiatry consultation for the kinds of patients that you and I have been talking about today. So thank you, Amita. That was a wonderful discussion. I'm very happy to have had you on the program today. And of course, we want to thank our listening audience for being part of this activity. We want to let them know that they should continue to answer the questions that follow and complete the evaluation